Thank you for having me. Nice to meet all of you. So I'm going to try to keep this short, just because I know the prior speaker ran over and people probably, need to get up and move a little bit, which is why I'm going to be talking about moving with myeloma. So why exercise? So this is a general overview. It's something that everyone should do, whether they were diagnosed with cancer yesterday, whether they were diagnosed with cancer 50 plus years ago, or whether or not they have cancer at all. But because this is a specific myeloma talk, I think it's important to discuss why. What's the point of getting up and moving? So it's been shown in multiple different cancer populations that it actually reduces the risk of cancer recurrence, right? So people take medications, they do surgery, they do radiation, do all of these things to prevent cancer from coming back. And so exercise, I tell people, is sort of like the cancer drug without actually being a drug. Similarly, it improves survival. Now, it hasn't really been demonstrated yet in the myeloma population to improve survival, but it has in breast and lung and GI and other cancer populations. It also, not surprisingly, reduces symptoms like fatigue and pain, insomnia, etc., and memory issues as well. And when you are moving, when you are feeling better, it increases your ability to return to work. So what are the guidelines for cancer patients? They were initially published in 2010 by the American College of Sports Medicine, and they really based it off prior guidelines that have been published elsewhere, like with the American Heart Association, but they recommended that people exercise 150 minutes per week of moderate intensity aerobic activity. So what does that mean? That means that people should not be, walking their dog that's sniffing every 10 feet, but it means that you should be able to walk at a pace where you're able to talk but not sing. Similarly, they also recommended including strengthening and flexibility exercises. Now, 150 minutes for a non-exerciser or even an exerciser can be difficult. I am a mom and I have 2 little kids, so meeting that 150-minute benchmark for me is usually a fail every single week, but I still press the reset button, and I tell people it's a goal that you should try to achieve. Now, these were updated in 2009 in the pre-COVID era, and they really recommended similar things, and this was just based on the accumulation of research studies that had been published in the prior 10 years since the initial publication of the guidelines. But they said, if you can bump it up to 300, great. But at the same time, 150 minute is really that gold ticket item. They also said that you should do it at least 3 times a week, so no weekend warriors. So you should break up that 150 minutes if you can, at least 3 times a week for at least 30 minutes. So really the minimum is 90 minutes if you can do it. So long story short, are people with cancer exercising enough? No. It's the simple answer. At this one study, which I published here, less than half meet the guideline, and that number really drops if you're talking about more of the metastatic population. However, when you get people involved in programs like the Live Strong program, more and more people meet that guideline. Now, there are social implications of that. When you join a group, you get to go to exercise, you make friendships, etc. But there are programs out there that can get people to meet that guideline. So what is a general exercise statement that I tell people, and that people that practice around the country like me tell people, is avoid inactivity. So if you're able to go up a flight of stairs, go up a flight of stairs. Go down 2 flights of stairs. Try to avoid using the elevator if you can. Try to return to normal daily activities. If you're someone that likes to garden and be outside and do things, do that as much as you can within reason. And generally, try to be as physically active as you are able to and as conditions allow. Now, when you're going through chemo, you're going to be tired. When you're going through treatment, you're going to be tired. And that's okay. But the antidote to fatigue is exercise. So if you're only able to get outside and walk for 5 minutes, that's better than spending an extra 5 minutes on the couch. So it's trying to grade it based on how you feel and how, things are going on a day-to-day basis. So when I meet with patients, I create an exercise prescription, and I use what are called the FIT principles. So that's frequency, intensity, type, and timing. So I will literally write it on a piece of paper so they can put it on the refrigerator, and I'll say, look, what do you like to do? If I tell you to go walk and you hate walking, then you're not going to do it. If you like to go swimming, and you, especially when going through treatment and you're a bit more immunocompromised, if you have access to a pool in your backyard or at a friend's house, great. Probably public pools are not the best. fast, but, trying to figure out where they are. In addition, meeting those numbers, trying to get it 3 times a week, 30 minutes at a time, etc., and build up from there. Strength training I'll get into a little bit later. In the myeloma population, you do have to be careful because you do have bony involvement, so you don't want to break something. But it's really about, guidance, doing it safe, etc. And as I'm sort of alluding to and circling around, before you start exercising, if you're a non-exerciser or if you're a prior exerciser and you need to get back into it, you need to be screened by a physician. What does a doctor like myself do? So we tailor your exercise program based on your medical history and at the same time trying to prevent injury. As I said earlier, my goal is to try to prevent bad things from happening. So it's really looking at your medical history, seeing where you are, seeing where you want to go, and trying to make those things meet. So what are things that I screen when meeting with patients? I want to see, do they have a history of heart disease? Do they have lung disease? Are they a prior smoker? Do they have COPD, etc.? I also want to see, do they have underlying neuropathy? Is it from diabetes? Is it from treatment? Do they have a bad back? Do they have, a prior broken foot hardware, etc.? I also want to see what their fracture risk is, and we'll go through that in a little bit. So just a couple of things. Can you exercise during chemotherapy? Yes, but you have to do it with certain precautions if your numbers are below certain levels. Previously, and I believe I get into this a little bit later, the mantra was back in the day to say, if your platelets are less than 50,000, you can't do anything. We now know that's not true. I actually did a deep dive a couple years ago to see where that specific number came from. And it was literally, and I hate to say this, but from some old guy writing it in a textbook with no literature to back it up. Colleagues of mine down at MD Anderson have really been looking into this in the inpatient rehab setting because it's much easier to study that cancer population versus the outpatient, and they've sort of disproved that theory. I know Memorial Sloan Kettering has their own guidelines, MD Anderson has their own guidelines. There's safety precautions that have been published in the rehab literature, etc. Similarly, if you're anemic, you aren't able to carry as much oxygen to your muscles when you're exercising, so you have to follow certain precautions with that. And similarly, if your white blood cells are low, then you're at higher risk for infection. So you, like I said, shouldn't be going swimming in a public pool, for example. So what about bony lesions? When I see someone with myeloma, I want to see where is their active disease. The areas that I care about really are the big long bones, so like the thigh bone, the upper arm bone, etc., in the spine, in the pelvis. And why do I care? Because I don't want them to break. Breaking bones is bad, and I try to prevent bad things from happening. The best predictor of a bone potentially breaking in an area of disease is if you've got functional pain. So what does that mean? That means if I have someone that says, oh yeah, I've got bony involvement in my pelvis, I've got bony involvement in my femur or my thigh bone, and I start to walk, and when I start to walk, it hurts, that's bad. That's when I'm calling my ortho colleagues and saying, hey, can we get a risk assessment for this to see, do they need an operative repair? Are there certain precautions to follow, etc. Now, I've listed up here the Merle's criteria. They were published almost 2 decades ago, which is crazy to think. But they really say this is your risk of fracture depending on, your score overall. And they go through, where it is, how much is involved in the bone, the type of lesion it is, and how much pain you have. But overall, when someone tells me they've got pain with weight bearing, that's when I start to get really concerned. So what are things, if you've got bone lesions, what are the no's? So when I come in to see patients, I always do manual muscle testing, meaning that I ask you to do things and I push against them to see how strong you are. If you've got bony involvement in those areas, I'm not doing that. I'm just seeing if you could do things anti-gravity usually. Similarly, if you've got lesions that are bothering you in your shoulder, etc., I'm only going to ask you to move your arms as high as you can without pain, and I'm not going to force it beyond that or ask you to do it yourself. You need to limit, as I mentioned, your range of motion by pain and using pain as your guide. Certain, weight-bearing restrictions are dependent on where there are lesions. Monitoring for functional pain is important. And spine precautions are good for everybody to follow, meaning that if you're bending over and you need to pick something off the ground, bend your knees. Don't bend and twist like you do in the car when you're driving and you reach for something in the back seat, etc. So why is overall function important? Why does rehab medicine exist? And why does cancer rehab medicine exist? Interestingly enough, the ability to do tasks independently is vital for a sense of self. So they did an initial study back in the New England Journal of Medicine over 20 years ago, and then they repeated it in one way a couple of years ago, and they basically asked people if treatment is going to cause an impairment of function, you're not going to be able to get dressed on your own, you're not going to be able to walk a certain amount. If we know that whatever treatment you're doing, if that's going to cause a functional issue, would you want that treatment? And the majority of people say no. Similarly, when compared with the risk of death, et cetera, from treatment, it makes people stop and think a little bit. And people with cancer in the older population, when presented with this question, would you want treatment causing a functional impairment or would you not? A lot of them say no. Not surprisingly, prognosis is linked to functional outcome. So the more functional you are, the more you can do for yourself, the more likely you're going to live and live better. Now, what are the predictors of functional decline in, the cancer population, in the myeloma population, et cetera? I've listed them here. Some of them I can change, other I can't. I don't have a fountain of youth, so I can't make you younger, unfortunately. Can I change things like smoking? Yeah, absolutely. But, that's also a socio-behavioral thing. It's a habit. It can be really hard. This is where, getting your overall functional status is important, which is something that I assess and ask everybody, and trying to increase it a little bit, before treatment, trying to maintain it during treatment, and trying to improve it after treatment becomes really, really important, because the more you can do for yourself, the longer you're going to live and the better you're going to feel. Not surprisingly, improved quality of life is associated with improved prognosis, right? Makes sense. Similarly, improved independence with what are called instrumental activities of daily living, or IADLs, is associated with improved survival. So what does that mean? If you are able to cook your own meals, if you're able to wash your own clothes, clean your own house, even though I don't like doing it, you're more likely to live, and you're more likely to live longer and better. It's that higher level of functioning that's really important in the cancer population. So how do you assess function? When someone comes in to see me, what are things that I ask about and things that I assess? So I want to see, there's ways to do it with self-reported measures. Are you able to get dressed on your own? Are you able to shower on your own? Are you able to go from the bed to the chair to walking on your own, or do you need help with that? Similarly, I ask about those instrumental ones, which are really important for survival, such as shopping, meal prep, etc. ASCO also recommends certain scales, and there's also clinician-based ones, which unfortunately are a bit more on the subjective side, because they're not directly coming from the patient. So what are some take-home points? Long story short, exercise is safe and is recommended in cancer, but before you start an exercise program, it's always important to check in with a physician to make sure you're not going to hurt yourself. Similarly, the goals are out there. As I said, those are the lofty gold standard goals. I tell people to reset it every week. If you only are able to do 30 minutes this week, great, try 35 minutes the next week. And modifications are important depending on your medical history, your blood counts, and the involvement of any bones. And that's it.